Today we have with us Dr. Amitav Banerjee, who is professor and head community medicine at Dr. D.Y. Patil Medical College, Pune. In his previous roles, he served as medical officer, epidemiologist at Indian Armed Forces and an associate professor, community medicine at Armed Forces Medical College, Pune. Speaking to him is Dr. Swadeep Srivastav, one among India's top health communication experts and founder of Heal Foundation and Heal Health, which have been at the forefront of health awareness through healthcare communications. Heal Foundation and Heal Health have been instrumental in creating campaigns and platforms for healthcare improvements in India for the last 2 decades.
So I'll start this session with setting the pretext of what Richard Simons said once in an interview with Men's Health magazine, that you can't buy it, you can't rent it, you have to earn it. My formula has been love yourself, move your body, watch your portions. Leading a healthy lifestyle sounds easy enough, right? Could be, but there's a lot of obstacles trying to divert our attention from eating healthy, making healthy choices, and exercising. Fortunately, when you are in the healthcare field, you may see the result of making unhealthy decisions, and it can help you lead a better life that is more fulfilling when you make the right choices. So I think, sir, your talk is also very much aligned with this thought process. And you once also said in one of your headlines, a century ago, the Spanish flu is estimated to have killed between 17 to 50 million people. Since 2020, SARS-CoV-2 is estimated to have taken lives of 5.5 million people, almost all of them either obese, already sick, or above the age of 70. So that is our overall topic of the episode is also, of course, so your focus has always been either sick, means with comorbidities, and your focus has also been emphasizing on a lot of data you have on the obese people, particularly falling prey to COVID and other diseases also. That's also a part of comorbidity.
So I have been tabulating the data since the onset of the pandemic of different continents and different countries actually. So at the beginning of the pandemic, say sometime in May, June, I tabulated data from 3 continents. And I found that there was a very close association with the obesity levels as measured by the increased BMI, more than 25, and the mortality from COVID. There was almost 10 times difference between the Western countries and the Asian and African countries. I mean, almost 10 times difference between the Western countries and the Asian countries, and almost 15 to 20 times difference with the African countries. So I tabulated the data and compared it with the BMI, that is the measure of obesity, and also the age. Because this was the year, it is a disease of the elderly, comorbid, those who are in nursing homes. So there was a good correlation with age. But what was surprising was there was a much more stronger correlation with obesity. Actually, at the population level, this obesity data is available from the WHO site. So obesity data can be compared across countries, and the COVID data can be compared. So this obesity data, what was interesting was that obesity was very strongly associated with and that obesity is a surrogate marker. That obesity per se increases the fatality from all respiratory diseases, not only COVID. If for influenza also there are papers, and subsequently there are papers that obesity increases the risk of severe disease and mortality from COVID also, because obesity causes the compromised respiratory functions. And also obesity is a surrogate marker of other comorbidities like diabetes, hypertension. So this is that it is you see, we require active involvement of the people to prevent. So actually people are becoming more passive. You see, to change, it may be just slight changes in lifestyle can cause a great benefit. अभी क्या हो रहा है कि people have become passive. Even पहले क्या टीवी का स्विच के लिए भी अभी बैठे बैठे रिमोट से हो जाता है. Then every program is passive, and they will watch the yoga program and not do it themselves. And they think that medication, that obesity reducing drugs or vaccines or medications, this should be used as a supportive treatment. But because people are going primarily for these passive interventions, like you take a drug for obesity or you take a vaccine for prevention disease, these are passive. So they are ignoring the more important lifestyle changes. And the lifestyle trend is going with the social changes or working space or home space or diet or recreation. Everything is changing. So I'll just go rapidly. So this is epidemiological approach is like we first do the descriptive, how much, as I said, what is the death per million people in different population. That is the measurement of the COVID impact. Then who are getting affected, the elderly or the obese, where, when and why. And then we make some hypothesis that this may be the reason. Then what can be done? If we find that obesity is related as one may, in the long term, we can say that yes, we should try to go for population weight control and how to prevent in future. And what difficulties are there? Like if we require cycling, we don't have cycle tracks. We don't have even walking tracks nowadays. We are having so much congestion of vehicles. So these are then we want to have good food. We don't have time nowadays. We go for fast food and all that. So these can be the difficulties in lifestyle change. They have no enabling environment. So we can think of, say, in office also, we can have some breaks of some recreation or something like that. Some of the companies are doing. They have yoga in the morning and then they start their work. So half an hour per day is good enough. Half an hour or 40 minutes of brisk physical activity, a brisk walk or some exercises is good enough for a lifestyle change. It is not only the obesity which may or may not reduce, but if you do even 10 minutes exercise daily or 30 minutes exercise, there are many changes, chemical changes, which are very protective for the overall health. And obesity would be a secondary benefit reduction. And this is the take-home messages. Throughout the pandemic, the Western countries are 5 to 10 times higher from COVID. जैसे मैराथन में एक लीड हो जाता है, मैराथन के एंड में भी वही लीड चल रहा है. और इस बीच में इस दौरान कितना कुछ हुआ है. We have had a lockdown. Some countries did not have lockdown. Sweden did not have lockdown. And if you see the data today, Sweden is, though it is in 4 digits because of its overweight and other things, but it is less than the UK and America and other countries which are strict lockdown. Similarly, Japan did not have a lockdown, and Japan rates are something like Asian countries. So all these measures, the more important measures have been the basic health of the people as measured by the surrogate marker of obesity. Age and more importantly obesity. Then Japan, Brazil I have already mentioned. In all this I have just discussed. And all these are related to lifestyle factors like physical activity, diet, tobacco, alcohol, stress, and there have been studies, there have been scientific papers which show that obesity, just control of obesity, the excess obesity explains 70 to 60 to 50 to 70% of the deaths could have been prevented. Children are also becoming very obese nowadays. Middle class children and the Western children are already very obese. In Western countries, the childhood obesity is higher than the adult obesity. And if you see in India also, the next generation children are more obese than our generation, because we always pamper our children. Usko chocolate खिलाएंगे, उसको cake खिलाएंगे, उसको ice cream खिलाएंगे, because we love our children. So उससे क्या होता है कि this lifestyle changes are there. What the research shows, as I said, as I go by data, a study, and even our institution has also studied that other problem, which is we do not have the lifestyle is not only diet and exercise, lifestyle is also outdoor. Vitamin D is a very important part of immunity. In fact, they have done studies, they have correlated the vitamin deficiency related to COVID impact also. And also vaccine impact. They have done studies that if a person who has got vitamin D deficiency, the vaccine does not work much, because the vaccine also works by stimulating the ability of the natural infection by stimulating. And if you have got vitamin D deficiency, neither your natural immunity works, neither your vaccine works. So, and we have done, of course, this study, vitamin D study, we have done 5-6 years ago, and we have found the younger generation was 10 times more deficient in vitamin D compared to the older generation. Because the generational wise, the paper we have published, the intergenerational decline in vitamin D, because nowadays everybody, even a this college student has got a car or a scooter, or they don't expose themselves to the sun rays. They just put sunscreen and other things. So there is vitamin D deficiency. And vitamin D, even I though I go outdoor and all that, I also had vitamin D deficiency recently. I am on vitamin D supplement. So now we are from people who are having a good diet. We think we are having a good diet, but somehow vitamin D is not unless you spend a lot of time outdoors, which we are not spending nowadays. And then comorbidities like diabetes, we did a survey. We have published these papers. Another thing is that young diabetics are there in India. Asian countries, all Asian countries have got a susceptibility to diabetes and heart disease a decade or 2 decades earlier than Western, because of a genetic central obesity and other things. And most of this young diabetes, 35 to 50 years, they are 50% of them are unaware of their diabetic status. So you see, most of the time you see कि जिसको कोई कोमोडिटी है, कोविड से ही सकम and the young age में आ रहा है. So most of the time, some studies elsewhere they have done, they have found undetected comorbidities which are not there. Similarly, it is for hypertension. Then risk factors, we did a study in even the rural areas, the risk factors of say fast food and sedentary lifestyle is gradually, we have done study, we found the risk factor for this diabetes, risk factor for obesity and hypertension are increasing in the rural areas also. These actually we are adopting the Western culture. In fact, long ago we used to study a lot in your preventive medicine courses about primordial prevention. So we never understood the concept what is primordial. So now we are understanding primordial prevention is higher than primary prevention also. That is, those prevent the cultural changes which are harmful to health before they come to a population. That is primordial prevention. So what are the cultural changes? Cultural changes are sedentary lifestyle, automobiles, fast food, and smoking, drinking. And so if a rural population was protected from these cultural changes, it is encroaching on that. So we have been failing in primordial prevention also because of the media, the advertisements and other things. So this cola drinks and this soft drinks which are full of calories. Studies reported with population level vaccination coverage. So this is in this whatever graph I said, and they have done other studies, the 68 countries and 2947 American counties. They compared the vaccination coverage and the trends of COVID trends. So they did not find a big impact at the population level vaccination coverage with the COVID incidence. And now we are seeing Israel also, they are having the 4th dose and still having very high compared to all the previous waves. So unless your basic lifestyle changes are there, you have got a basic good health, neither your natural immunity works, neither your vaccine works. So this is the healthy meal. This is a Japanese diet. Of course, I don't know what is Japanese diet, but I have taken this from the net. This is Japanese diet because I found they were the healthiest people. So I said, चलो ये क्या खाते हैं, देखते हैं कौन सा चक्की का आटा खाते हैं ये, like गब्बर सिंह. So अभी क्या है कि पर खाना देख के तो अच्छा लग रहा है क्योंकि हमारा भी डाइट ऐसे ही मिलता जुलता है. ये देखिए राइस है, फ्रूट्स है, वेजिटेबल्स है. So we also eat. Actually, basic Asian diets and other things were already very healthy actually. So I don't see much difference when I have a look at this from Indian diets. Whether India has got such good variety of diets, South Indian diets, Marathi diet, Gujarati, all are of natural cereals, all are full of natural vegetables. And these are what we are changing over to the fast food. Burger and so this is the youth is changing over. The next generation already. And with that, instead of water, they will take that Coke or Thumbs Up or Fanta. That is full of sugar. That is they say sugar is the new smoking. You see, sugar is the one which causes all the problems. Instead of that high cholesterol and fat, now that hypothesis is also changing. So this is what is happening. And this is over the period of lockdown, they have done studies in USA. People have gained 5 kgs, 10 kgs, 20 kgs weight. So this lockdown and restriction of movement is making you more vulnerable to infections.
If you see the plate and the picture of Indian diet, forget about the American burger and all those diet chips and all. But even in Indian diet, sir, don't you think that the portion of rice, roti is much higher than vegetable and dal if you look at the overall plate? Whereas in Japanese or even in foreign countries, whenever we go in Europe or US or we travel and we eat at the restaurants, so we see that there's always a lot of emphasis in terms of the filling the plate with more vegetables and maybe beef or the chickens and everything, and less of bread or everything. Everywhere you start with some salad or some more rich veg. So is there any data available on this that Indian diet are Indians eat more carbohydrate compared to other countries. That's why that can be one of the reasons of imbalance in overall nutrition, sir.
You're perfectly right, Dr. Sadeep. Indian diets are high in cereals, and it's like rice and wheat, which are almost 60-70% they get the calories from carbohydrate. So there is, of course, these carbohydrates are not very desirable, as you said, if you are having excess of carbohydrates, but they are less harmful than very rapid carbohydrates like sugar, maida. So if you take, multi-grain, they take now, we combine it with bajra or wheat. They are also carbohydrates, but they do not have that sudden rise in blood sugar. Glycemic index is less, firstly. Secondly, as you said, the too much of rice, it is a matter of economics also. Poor people cannot afford too much of vegetables. Fruits are getting very costlier. So they cannot afford. So for them, the staple diet will be a bowl of rice or a big thali of rice. I have seen poor people eat it with some salt and water also, nothing else, because that they have to fill their year. But fortunately, what happens, the poor people, they are working more also. They are doing more physical activity. 6-7 घंटे वो काम करता है, तो उसका क्या होता है कि उसका कैलोरी इंटेक मैच हो जाता है. And awareness among the rich people, they can afford to have a variety of diets and cut down on carbohydrates. They can have fruits. They can have actually 5 helpings of fruits are recommended. Minimum 5 helpings, 35 gram in each helping. Almost this 5 helpings of fruits and lot of vegetables. So that gives a diversity. They say as much diversity in the diet and cutting down on the carbohydrate. Firstly, refined carbohydrates, and secondly, as you said, the other too much of rice, which can form the bulk of the year, can be unbalanced a little. But poor people cannot afford it. So we can have some consolation that they work it out. They do the physical activity, so the balance remains, and they can, if they are working in the fields, they may take some gajar or mooli or something. They take vegetables also. They may be munching, but that awareness can be increased. And the poor people can be told to grow their own vegetables, like kitchen garden, other things. So that way, it may be a matter of economics.